Hi, my name is Will Pegna. I am a neuroendocrine tumor medical oncologist at OHSU in Portland, Oregon. And today I will be talking about navigating somatostatin analogs and chemotherapy for neuroendocrine tumors. So, starting off, these are my disclosures. All right, the goals of our talk today are to one, understand what somatostatin analogs and chemotherapy do, two, to learn when each treatment is typically used, and three, to know what to expect and what questions to ask your care team. So, as we jump into this discussion here, it's important to see where it fits within the neuroendocrine tumor journey. And what I mean by this is that neuroendocrine tumors are not just one disease. As you know, these tumors can originate from multiple diverse primary sites, and they can behave very differently from slow growing to much more aggressive cancers. There are even certain of these neuroendocrine tumors that can secrete hormones that can cause severe symptoms in and of themselves and affect organs that are otherwise cancer free. So, along this line, neuroendocrine tumors are often treated over a period of many years, if not decades. And as such, treatments are oftentimes added step by step. They may be recycled, they may be reused, and they're really driven by patient context and really with an idea in mind of three goals. For all patients, we're hoping to control tumor growth, to control symptoms. And for many patients, as I mentioned, there's this idea of controlling hormone secretion, which is part of controlling the overall symptoms and the long term disease course. So, to start off with this, we'll start talking about somatostatin analogs, oftentimes shortened to SSAs for short. These are medications that are similar to the hormone somatostatin. If you look here, many of you have seen dotatate PET scans before. So, if we really zoom in on the neuroendocrine tumor and we look at it at a cellular level, many neuroendocrine tumor cells will express a somatostatin receptor on their surface. This somatostatin receptor binds to the hormone that naturally exists in our body called somatostatin, and that receptor binding sends a signal through the neuroendocrine tumor cell, which is really a stop signal. This indicates to the tumor to slow down its growth, slow down its reproduction, and also to reduce hormone production and secretion. So, our somatostatin analogs are medications that look very similar to the hormone somatostatin. They include Octreotide LAR as well as Lanreotide. There's also a short acting version of Octreotide that also is available as a subcutaneous injection. Common side effects of these medications include injection site discomfort, mild gastrointestinal symptoms such as diarrhea or even constipation in certain cases, and over long term use, gallstones. So, starting off with tumor control, somatostatin analogs are oftentimes the very first treatment that patients will receive for their neuroendocrine tumor. And both octreotide and lanreotide have been shown to delay tumor growth. What I have on this slide here is an oncologist's favorite graph that comes out of clinical trials. This is called a Kaplan-Meier curve. Although it seems complicated, the general idea is on the vertical axis here, you can see the percentage of patients who are alive and their tumor has not grown. And on the horizontal axis, you have time. So in the original studies, both lanreotide and octreotide over time showed that proportionately more patients were alive with their tumor not growing, really over a period of multiple years. And so we have both of these drugs available for the purpose of slowing down tumor growth, controlling the tumor, oftentimes when it is first diagnosed. And the selection between these, we'll talk a little bit more about this, but this is based on practical factors as well as patient preferences. Now, somatostatin analogs also play a critically important role in hormone control. And as I mentioned, they send this stop signal that's acting to directly stop hormone production and secretion. And as such, these are the mainstay of treatment for many of our hormonally related syndromes that can occur with neuroendocrine tumors. So, what are these syndromes? Most often coming from small intestine neuroendocrine tumors, less often from lung neuroendocrine tumors, is the secretion of serotonin or serotonin like peptides that can cause the classic carcinoid syndrome, including diarrhea, flushing, wheezing, and in its most advanced and kind of its most severe state, heart disease, valvular dysfunction, and even heart failure. Pancreas neuroendocrine tumors are much less likely to express hormones, but they can also create very severe syndromes as well. Some of the hormones that can be secreted include gastrin, which triggers acid secretion in the stomach, which can lead to ulcers, insulin, high levels of which can result in low blood sugars, glucagon, which can cause the opposite and very high blood sugars. VIP, vasoactive intestinal peptide, can cause severe diarrhea, or a very rare entity where somatostatin is actually secreted, which results in gallstones. So really, somatostatin analogs are critically important for the purpose of slowing down or stopping hormone release. And even if the tumor grows, we oftentimes will continue the somatostatin analogs in spite of this because of their continued impact on hormone control. So going back to the question of which one, Lanreotide or Octreotide, well, they've never been compared head to head. We generally consider them to be similarly, if not equally effective. And so the choice of which one to use is usually driven on practical and patient specific factors. It used to be that we were a little bit limited by insurance, one over the other, but nowadays really it mainly comes down to sort of patient and provider preference. And what this comes down to is how these drugs are given. So Lanreotide is given as a deep subcutaneous injection. So the idea is that the injection goes through the skin into the connective fatty tissue that's below the skin, whereas Octreotide LAR is a deeper injection that goes through the skin, through the subcutaneous tissue, and into the muscle itself. So Octreotide, this IM deep injection, may be preferred in patients who have very thin skin or otherwise have less subcutaneous tissue, less subcutaneous fat, whereas Lanreotide may be easier when intramuscular deep injections are difficult. So now comes the question of what do we do if symptoms break through? Well, from a hormonal perspective, we can always consider increasing the dose or the frequency of both Octreotide LAR as well as Lanreotide. But from a tumor control, there is also some experience and even some clinical trial data suggesting that there may be some benefit from increasing the dose. Now, what I have on this chart here is another Kaplan-Meier curve from the original NETTER-1 trial that led to the approval of PRRT, but the PRRT, the Lutathera, is being compared to a double dose of Octreotide LAR, or what they call high-dose Octreotide. What we can see in this graph is that although, yes, Lutathera is clearly superior in terms of progression-free survival benefit, at 8 or 9 months, more than 50% of patients, their tumors had not grown during that time period with this high-dose Octreotide. So this at least suggests that this is a possibility for continued disease control. And as I mentioned, we oftentimes will continue the Octreotide or the Lanreotide in order to control hormonal symptoms, even if the tumor has progressed. In certain cases, we may even continue it if we think that it may be slowing down the tumor, if not altogether stopping it. So somatostatin analog therapies have been along for quite a long time, but these are actually an active area of research at this time, with goals of research including to improve the hormonal and symptom control, more convenient administration, and more consistent and higher average drug levels. Examples in development include CAM 2029. This is a bi-weekly subcutaneous Octreotide depot option with a possibility of self-administration. And then paltusotine, this is a once-daily oral non-peptide somatostatin analog being studied for the control of carcinoid syndrome symptoms. Now, importantly, we need to know that these drugs remain investigational. They're not currently available outside of clinical trials, but we do have some hope that maybe some of these will move through clinical trials and be available in the future. So when do we move beyond somatostatin analogs? For one, of course, if the tumors are clearly growing through multiple CT scans and we don't think they're providing that disease control. Second, if we're getting breakthrough symptoms, be it hormonally or other symptoms, in spite of dose optimization and otherwise for these drugs. Then also, if the disease starts behaving more aggressively, oftentimes the somatostatin analogs are not the best option for controlling disease. Similar to that, on initial diagnosis, if a patient has higher grade disease, we may jump to different treatments such as PRRT, Lutathera, or even chemotherapy in certain situations. So this transitions us well into talking about chemotherapy for neuroendocrine tumors. So chemotherapy works by directly killing tumor cells. They are oftentimes used for pancreatic neuroendocrine tumors as well as for faster growing or higher grade disease. The main goal of chemotherapies tends to be tumor control, including stabilization or shrinkage of disease. But they may also sometimes be beneficial for hormonal symptoms, but this is really not really the primary goal or expectation of these treatments. The side effects are very different from somatostatin analogs and really depend on the regimen that is used. So it's impossible to not talk about chemotherapy without including a net oncologist favorite combination, which is capecitabine and temozolomide, or CAPTEM for short. This is an oral-only chemotherapy regimen that combines capecitabine given on days 1 through 14, as well as temozolomide on days 10 through 14, followed by 14 days off. This combination tends to be exceptionally well tolerated compared to many traditional chemotherapy regimens, though it does have some side effects, including fatigue, nausea, low blood counts. Constipation is also possible as well. Now, very importantly, as of 2026, there is a genetic sensitivity to capecitabine that all patients should be tested for before starting this combination. This is called DPD deficiency. DPD is an enzyme that breaks down the active chemotherapy component of capecitabine. And in 2 to 4% of the population that have a genetic deficiency of this enzyme, what we can see is much higher levels of the drug causing more severe side effects. So as of 2026, we really want to have all patients tested, if feasible, before starting capecitabine. Other chemotherapy options include the colon cancer regimen FOLFOX, which is the combination of 5-fluorouracil with oxaliplatin. There's really good data to use these, especially pancreas neuroendocrine tumors that have been treated with multiple other agents. There's a much older regimen combining streptozocin with or without 5-fluorouracil. It still has some utility in certain neuroendocrine tumor patients. And then the platinum chemotherapies, cisplatin or carboplatin combined with etoposide, are really typically reserved for much higher grade or aggressive disease such as neuroendocrine carcinomas. So when we think of somatostatin analogs and chemotherapy and how decisions are made, this brings us back to the idea that neuroendocrine tumors are just an incredibly diverse set of diseases. As such, treatment decisions are individualized and based upon symptoms, the behavior of the tumor, side effects and quality of life expectations, as well as patient preferences and goals, which that last one is oftentimes of critical importance as we're navigating these different treatment options. Now, it's important to keep in mind that there are multiple effective treatment options that are often available over a long period of time, and new treatments are constantly being developed. Oftentimes, I have this discussion with patients of, well, why are we doing this treatment if we don't expect it to make the tumor go away or shrink, but rather just keep it stable? And it feels like we're just kicking the can down the road. That's exactly what we're actually aiming for in certain cases, because there are new treatments coming down the pipeline constantly. If we can minimize symptoms, minimize disease growth, and we treat this over a longer period of time, this really allows us to take advantage of all these advances that are going on in neuroendocrine tumor research. So some questions to ask your oncologists, really with most any treatments, but when it comes to somatostatin analogs and chemotherapy as well, is what is the goal of my treatment? How will we know if it's working? What side effects should I expect? And really, especially when it comes to the capecitabine nowadays, are there any genetic tests or otherwise that I need before the treatment? And here I'm really referring to the DPD testing. And then, as I mentioned in the last slide, are there clinical trial or other options that I should consider? Clinical trials are really just the critical way that we move this field forward and that we develop these new treatments. So I always strongly recommend pursuing these whenever that's a possibility. So some key take-home points that I wanted to make sure to emphasize. Again, neuroendocrine tumors, highly diverse cancers. Treatment decisions have to be individualized. Octreotide and Lanreotide are foundational therapies that help control both tumor growth and hormone symptoms. Chemotherapy is generally used for more progressive or aggressive disease and can be very effective and well tolerated. Multiple treatment options are oftentimes available over time, and patients should understand the goal of each therapy within the greater context of their journey. All right, and with that, I'd like to say thank you to the Neuroendocrine Cancer Foundation for having me here today, as well as all of our viewers at home, the OHSU Neuroendocrine Tumor Program, as well as the OHSU GI Oncology Clinical and Research Team, and of course, our patients and their families who make all of this possible.